Well, before I start, I am a pharmacist, so I am going to talk about pharmacy research. But I need to say that the program of research has been about establishing the evidence base from pharmacy. What I'm about to say doesn't preclude what everybody else can do about asthma in the community, and that in fact, having brought the evidence forward for what pharmacists can do, we all firmly believe that the time is now ripe for healthcare professionals across the spectrum to work together. But there was a feeling many years ago that perhaps pharmacy didn't have anything to bring to the table. I'll show the evidence that they can. Having provided the evidence, it's now time for us to get involved in the team. So hopefully this is not too boring for those of you who are not pharmacists. We all know that we've got good medications for asthma. In fact, originally I was investigating basic mechanisms of the disease process and looking for new medications. In fact, we have good medications. But in order to work, they've got to be taken. And the two things that influence whether the patient actually takes the medication is, firstly, inhaler technique is extremely poor, and adherence can be poor. Now, I use the word poor, that's by some kind of standard, but in fact, lots of patients are making decisions about whether they take their medicines based on all sorts of information that they have available. But good medicines don't get in because the inhaler technique's poor, and secondly, it's not actually even being used in the first place. Patients make their own decisions about healthcare. Asthma patients are particularly good at this. A lot of them have had asthma all their life. They've had lots of asthma education. They're experts, and they don't necessarily want to be told too much. However, the disease is much more difficult to control without regular medication, certainly in a large proportion of patients. And the majority of care of asthma is out in the community. So originally it might have been seen as a specialist condition, but now asthma really, and if you talk to thoracic physicians, they say they rarely see asthma. They're busy with other diseases, pulmonary fibrosis, COPD, but asthma's a primary care issue. The healthcare system's overloaded with patients with chronic disease, and there's a whole range of time-poor healthcare professionals out there. The poor GP has got to worry about patients who are obese, who are on the line to diabetes, who may have COPD. He or she really thinks that asthma is kind of taken care of, and besides which they've only got a 10-minute consultation in order to address quite a complex problem. The last thing is that healthcare professionals, and this will be no surprise to you, have very little idea of what each other is doing. So from the pharmacy perspective, knowledge associated with health and disease management is ever changing. So pharmacists, as well as all other healthcare professionals, need to uptake the knowledge and then transfer it to people with asthma in the community setting. How they do that needs to be looked at. Pharmacists spend a lot of time learning and keeping up to date on medications. In fact, if you do continuing education with pharmacists about medications, they think it's boring because, I hope you don't mind my saying that, but they know about medications. Most importantly, they're the last healthcare professional to talk to a person with asthma before they usually, if they're going to take their medication, before they actually take it. So an opportunity exists to help people manage their asthma effectively with their medications. So I'm going to talk to you about this paper a little later in the afternoon, but I just wanted to highlight the problem. We assessed 570 people with asthma in community pharmacy, so they were being taken care of in primary care. They were enrolled by 96 pharmacists across Queensland, New South Wales, ACT and Victoria. And they were recruited as they requested an asthma medication, be it either Ventolin or a prescription. And what the pharmacist did is assessed asthma control, either using the ACQ, the Juniper 5 questionnaire, or an NAC table, which we'd modified to use in the pharmacy, which actually classified asthma control as poor, fair or good. But both are basically based on symptom reporting. The pharmacist assessed inhaler technique, lung function. In this particular study, they did spirometry, medication adherence, health beliefs about their asthma and their medication, triggers for their asthma, and they reviewed their medications. What we found, and I'm just setting the scene here because I'm going to talk about another study, is that of these patients, 77% had poor asthma control. And 69% were already using combination therapy. So despite using what you would recommend for this group of patients, they still had poor asthma control, which suggests there is a problem with medication taking. Depending on the device, between only 17 to 28% use their inhaler correctly. So at the high end of the spectrum, it's still less than 30%. And then we did modelling to look at what influenced that poor asthma control. So we had all these variables associated with each patient and then put it into a model to said what influences whether you have good or poor asthma control. And incorrect inhaler technique, smoking and low adherence to medications were the things that correlated with poor asthma control. And so it's the incorrect inhaler technique I'm going to focus on now. What are the consequences of poor inhaler technique? They're pretty substantial. Okay, if someone has incorrect inhaler technique, then they're actually receiving a subtherapeutic dose according to what the medication's supposed to deliver. The asthma is uncontrolled, and in some cases they have increased number of emergency visits. They also may get the dose of their medication increased because the dose that they have is not working. That leads to increased side effects and will increase the cost of the medication. This leads to decreased patient satisfaction with the medication, and they actually don't go back for an asthma review because their last interaction resulted in something that they weren't very happy with. So the consequences of incorrect inhaler technique are wide. Inhaler technique issues. Aerosol deposition and the resulting therapeutic response are critically dependent on the patient's inhalation technique. I'm sure I don't need to tell you that. If someone has incorrect inhaler technique, then the dose expected to reach the lungs can be half or even lower than that which is expected with that medication and that device. Now, not just our studies, but plenty of others have shown that up to 94% of patients use their devices incorrectly. So in many diseases, adherence is a problem, but in asthma we have an additional thing in that even if it is being, the medication is being taken, it's not being used correctly. Mostly patients are unaware of it or stroke uninterested. And healthcare professionals, as I mentioned, need to focus on other things. And a lot of healthcare professionals, including pharmacists, have poor technique themselves. And so they lack the confidence to actually go about doing something about it. Now, we all know that pressurised metered dose inhalers are difficult to coordinate and that you can use a spacer. And that can increase the lung deposition from about 8 to 21%. However, for a lot of people, the DPIs are a little, MDIs are a little cumbersome and the spacers are sometimes not practical. So the dry powder devices, which is what I'm going to spend a bit of time talking about now, you don't need to have the same coordination for actuation and breathing. So they do offer that advantage. So you would think that technique would be perfect, but it's still less than optimal, of course. And goodness knows, why are people confused? Look at all the devices that are available. And it's not surprising that healthcare professionals and patients are confused. And if the device gets changed and there's not necessarily any education that goes with that, then patients can do rather amazing things with devices that you wouldn't necessarily think that they might. And I'm sure you've got plenty of stories along those lines. Okay, so I'm going to focus on dry powder devices because that's the study I'm going to talk to you about, and there's certainly enough of those. So the dry powder devices, they're efficient devices, but of course they are not correctly used. So for the turbuhaler and accuhaler, which are in the study I'm about to tell you about, incorrect technique is common for both devices. At least about half the people who use them have incorrect technique. What about healthcare professionals? How do they do? And this will vary what type of healthcare professional, and you see there's a broad range in here, so you can imagine where you might be on the spectrum. I reckon I'm at 85%. Where do you think you are? I think that it's very common for healthcare providers to have very poor technique. Pharmacists, and we've measured this, for the turbuhaler between 43 and 71% have incorrect technique, and accuhaler about 55%. So what's the problem in talking to people about technique? Lack of confidence, perhaps, lack of skills, and also the perception that the advice may not be welcome. When you ask people with asthma, what do they say? They say the source of advice on inhaler use from their regular medical practitioner is about 75%, and only in about 8% has the pharmacist given them advice on their inhaler technique. And I should mention this study was done in 2005. It was done with our PhD student, and it was a PhD student that Dr. Helen Riddell, Dr. Cynthia Bosniak-Anticevic and myself worked with. Dr. Bashiti is now in Jordan fixing up inhaler technique over there. The mode of information, of education about inhaler technique, both verbal information and physical demonstration had been used when patients had been shown how to use their devices. And when was the instruction received? Well, it's okay. About 96% had got it when they first got the device. What about subsequent checking of technique? By the pharmacist, about 3%, and by any other healthcare professional, about 11%. So given that inhaler technique, once you learn it, it's not perfect for the rest of your life, this is a bit of an issue. In order to improve inhaler technique, there's a few things to consider. The mode of delivery of education is important. So a physical demonstration or a video, so where there's something to see, is better than just verbal instructions, is obviously better than written, and I'm sure you all know that, but that's been shown in the literature. But the person with asthma must be asked to demonstrate after being shown, because you can't assume that the message that was delivered here is the one that was taken on board. The other thing that the literature shows us is that education must be repeated. And as soon as 2 to 6 weeks after education, inhaler technique deteriorates. So it needs constant reinforcement. Good news is, if you educate healthcare professionals, they retain good technique for much longer periods. So they retain it for, and we've shown this, for about 2 years. So they don't need the same reinforcement. Okay, there is a way to check inhaler technique, and this is very well documented. And so we use these 9-point tick-point inhaler checklist to look at inhaler technique. So the study that we set about to do with our colleagues was a study that looked at pharmacists, intervening with pharmacists who then used a train-the-trainer approach to look at what we could do in terms of patient education and self-management. So in the study, we had two groups of pharmacists. They were randomised to either an active or a control group. The control group, what was delivered is we assessed and refined peak flow meter technique. So that's what went on here, so about measurement. And in this group, peak flow meter technique was worked on, but so was dry powder technique. And then these pharmacists then went on to recruit patients, both those using a turbuhaler and an accuhaler, and in the control group the same. And I'll show you the plan in a moment. In this case, pharmacists themselves were assessing inhaler technique. In this case, the student, Dr. Bashiti, actually went and tested their technique separately. So there wasn't interference from the pharmacist, if you like, about technique. It was actually being assessed, so we had a control group. So firstly, we tested and improved the technique for pharmacists in the active group. And then as the active group, they assessed and delivered inhaler technique education at baseline, then 1, 2, 3 and 6 months. And the pharmacists just followed up the patients, but just measured their peak flow. So how did the pharmacists do? So both the active and control group, the percent of pharmacists who had 100% technique, so scored 9 out of 9, was about 10%. So that's both for the turbuhaler and the accuhaler, and as I said, for both groups. Now, after the education, because of course that only happened in the active group, the technique improved in both groups to about 90% for the turbuhaler and just under 80% for the accuhaler. So firstly, educate the pharmacists, and this is the study that reported that. So we used the train-the-trainer educational model, and the training was quite short. And then following the implementation process, the education model resulted in improved clinical, humanistic, and actually health outcomes, but also greater satisfaction for people with asthma in the community. And I'll show you the details of that now. So what was the intervention? The intervention was assess technique with the checklist, so the pharmacists all had good technique now. Then educate about the incorrect steps, then assess technique. If it wasn't 100% correct, then go through the education again and do 3 cycles of that. That's when we stopped, and the majority of patients had 100% technique by then. Then for the patient, the pharmacist highlighted on the label, so they had the 9 steps for that particular device, and they highlighted the label with the initial problem where they had to have the education, so the weak point, if you like. And then they attached that label to the inhaler. And that's what it looked like. So it was very, there was some reinforcement for the patient about where they'd had difficulty. They'd been shown how to use it properly, but they knew to focus on these steps when they were actually performing technique at home. So what actually happened? There were 15 pharmacists in the active group and 13 in the control, and they recruited, the active group recruited 23 turbuhaler patients and 30 accuhaler patients. And not surprisingly, baseline inhaler technique was poor. So, in fact, they did a little better than the pharmacists, some of them. So they had around 20% here, between 10 and 20%. So this is to get 100%, 9 out of 9, and none of the patients did that. So I'm going to concentrate on the turbuhaler information, but the information is very similar for acuhaler. So as I mentioned, there were visits to the pharmacy at baseline, 1 month, 2 month, 3 month and 6 months. And what is the inhaler technique score? And as you can see, quite rapidly inhaler technique improved, but there was continuing improvement up to 3 months and a slight suggestion that it's falling off. And between 3 and 6 months there was no subsequent education. That's in comparison to the active group, where there was an effect because they were having their inhaler technique checked outside, but it's significantly higher in the active group. At the time we did this study, the classifications were around asthma severity rather than asthma control, and so we used that classification. And what happened is, so this is the active group and the control group. I'm sorry it's a bit small. But at the beginning of the study, then according to their level of asthma control, the majority of patients either were moderate or severe. What happened as a result of the study is that you had more patients moving to the left, which is actually what you would want. So more patients with mild and moderate, and fewer patients in the severe category. And as you can see, the movement in the control group was nowhere near as great as the active group. In terms of lung function, so we were measuring peak flow in both groups, and my colleague over here, Dr. Riddell, is an expert. I think you invented this, did you, Helen? This peak flow variability is an estimate of how variable the lung function is. So it gives an idea of how well asthma is controlled. And as you can see, in the active group, there was less variability, which is what you would want over the 3 months, and it was certainly improved more than it did in the control group, with some falling off as we left the patients alone for 3 months. There, in the active group, the reliever use went down significantly. Whether that was maintained is probably not true, so they went back to old habits. Their quality of life improved, so better quality of life is a lower score. So in the active group that we're getting and they're only getting inhaler technique education, that's all. It improved, and we only measured it at baseline in 3 months and then 6 months, and it stayed the same in the control group. And their perceived control, how well they felt that they had control over their asthma from a patient perspective, went up significantly in the active group and stayed somewhat similar in the control group. So in the active group, how many times did they have to go through that cycle, that show and tell counselling? So at the beginning of the study, this is 3 times, and then down to the mustard colour, which is 0 times. So at the beginning, obviously they had to do that a number of times, but with subsequent visits, the number of show and tell counselling episodes became fewer. So the big question every pharmacist is going to say is, yeah, but how long did it take? So after what we have here is the time for the inhaler technique education. So it did start out at about 6 minutes, but over the period of the study, it fell down to about between 2.5 and 2 minutes to check inhaler technique. And obviously in those that had very good technique, it was quite short. And what happened with pharmacist technique? Well, fortunately, it went up really rapidly and it was maintained. So that was maintained over 2 years. So by getting technique to be optimal in the pharmacists, it was maintained for 2 years, and that meant that they could deliver that education for patients. We have very similar results for the Acuhala. So inhaler technique is really poor. I'm guessing you all know that, but we've got the evidence that that's the case. Both pharmacists and patients have got poor technique, but it's not that hard to improve technique. I've talked to you about a simple intervention around dry powder inhaler technique, but there's lots of literature around other kinds of devices and how quickly it can be improved. We used a train the trainer approach where we trained the trainer, we trained the pharmacist, but any other healthcare professional obviously can do this. The great advantage is the pharmacist is the one that's handing out the medication. And it was a very brief evening workshop. So it wasn't days of education, it was one evening. And the benefit was retained for 2 years. We used the labels as a reminder to the patient, but also to the pharmacist, so the next time they came back, they had the points to focus on. It's feasible for delivery in community pharmacy because it takes less than 5